Good morning, everyone, and welcome to this week's Department of Medicine Grand Rounds. Before we get started, a few housekeeping points. Please make sure your mics are muted during the presentation. Also, we kindly ask you to hold your questions and comments till the end, at which time you may unmute yourself or put your questions in the chat box. Lastly, the CME credit on the screen will be displayed on the second slide and at the end of the presentation as well. Today's speaker is Dr. Takeshi Uemura. Dr. Uemura is an assistant professor of medicine in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, with extensive clinical experience in geriatrics and palliative medicine. He earned his medical degree from the University of Toyama in Japan and completed his residency at Mount Sinai Beth Israel in New York. This was followed by a fellowship in geriatrics and palliative medicine at the Mount Sinai Hospital, and a medical education fellowship from the University of Hawaii. Dr. Uemura's clinical and research interests expand from the utilization of artificial intelligence within palliative care and geriatrics to the impact of communication training among physicians. He recently received certification from the Massachusetts Institute of Technology for AI and machine learning. Dr. Uemura currently serves as the GME Wellbeing Champion for the Fellowships of Palliative Medicine and Geriatrics at the Icahn School of Medicine. Please join us in welcoming Dr. Uemura and his presentation on pain management in older adults.
Thank you, Steve. Thank you, Steve. It's my honor to see you all about this. And I'm speaking to my name. And then I agree with all the others.
Dr. Uemura. Dr. Uemura, I'm sorry. But your mic sounds different. So when we did the testing a couple of minutes ago, it sounds like a robotic sound. We can hardly understand.
Okay, let me. How is it right now? No.
It still has the same robotic sound.
I'm sorry. Hold on one second. Let me maybe try this.
It's like also garble. I don't know. If just approaching to the mic might improve it. Sit closer to the mic, perhaps.
Hold on one second.
What about right?
Try it again.
Hold on. What about right now? No?
That sounds better.
It's better.
Okay, it's better?
Yes, it is.
Okay, all right. I apologize for that. Yeah, but let me know if you don't hear me well, and then I'll try to fix it. But anyway, so I was saying that I'm trained in geriatrics as well as palliative medicine. And then I work at Mount Sinai right now hospital, working as a geriatrician as well as palliative care. I do inpatient consult service. However, I have extensive experience. I'm going to talk about my story actually later, but in treating pain in older adults. So I'll get started, but it's a very complicated topic. So I try to dissect in 4M's approach. So as in the title, I'm going to use 4M's approach to explain this pain management in older adults. So next slide. So CME code is here. So I'm sure you want to get the credit. So this is the code. Okay, I'm going to go to the next slide. So there's no disclosure. So objectives, sorry. Okay. So utilize the 4M's, which is mentation, medication, mobility, and the matter most. I'm sure some of you have heard of this 4M's to develop comprehensive patient-centered pain management strategies, and also describe the challenges and the unique considerations in assessing and managing pain in frail and then cognitively impaired older adults. And also discuss evidence-based pharmacological and non-pharmacological interventions, emphasizing the principle of start low and go slow to minimize risks. So actually, before coming back to Mount Sinai, where I did the fellowship, I was also at University of Maryland, and this is the University of Maryland. Also, it's huge center. And then I was doing a palliative care consultation there. So I worked in a very huge academic center doing managing the pain in that setting. However, not only that, also I was in nursing home. So I was a medical director of nursing home, and you can see this aloha shirt, so you can guess actually it's in Hawaii. So after fellowship, I went to actually University of Hawaii, and I worked as a medical director at nursing homes. And actually, that was when I realized that pain is a huge issue in older adults. And then because I was trained in palliative medicine, not only geriatrics, so I was able to apply, some skills and the knowledge I learned in palliative medicine in order to optimize pain management in nursing homes for older adults. And also because actually also I did the home hospice as well. So I was all over the place. And you can see again, this is in Hawaii because I'm wearing aloha shirt. That's how they work, by the way. They don't wear a lab coat over there. But again, there also, it was very important for me to treat pain in older adults. So based on this extensive experience, I'm hoping to give you some, like clinical tips, how you can optimally treat pain in older adults. So as you may know, pain is very common in older adults. So highly prevalent among older adults. Some study says, 25%, as high as 80%. Right? And then conflicting more than 20 million older adults in the United States. And then because I worked in nursing homes, so I especially interested in pain in nursing home. So chronic pain in nursing home is also very common. Most of them are very old, very frail, debilitated. And then pain prevalence is, depending on the study, but the 43% or 82%. And then, of course, pain impairs physical function and reduce quality of life. And not only that, it is associated with many like behavior or psychiatric problems such as agitation, depression, poor sleep, and reduced quality of life. But also they refuse care, nurse trying to touch them or give them medicine or turn them to clean, and then they refuse or try to hit them, right? And then wandering also, it is associated. And again, it can be physical aggression as well toward staff. So it is a serious problem. However, also, as you may know, the pain in older adults are under-detected and also under-treated. Again, among nursing home residents, one study showed that only 15% of them received pain medication in the previous 24 hours, even though they had like persistent pain. And also in nursing home, 62% not receiving any pain medication, even though they have persistent pain. And then 16% of them only receiving as needed, again, even though it's persistent pain. And then cancer patients of, older age, and then only 26% receive no analgesia. So it's often under-detected and then under-treated. So you may have also experienced treating pain in older adults or realizing this is pain is challenging for clinician in general. So because pain is very complicated topic, so I decided to dissect this topic based on this 4M's approach. And then I'm sure actually Eric Chen, the geriatrician at your university hospital, is a friend of mine. We did the fellowship together, and I'm sure he has talked about this for AMS, but this is a famous framework we means geriatrician use in order to provide some like comprehensive assessment and a treatment plan for older adults. So I'm going to use this framework. So it's for AMS composed of this what matters most: medication, mentation, and the mobility. So I'm going to go over mentation first. And mentation normally include 3 Ds. We like abbreviation, as you can see, but 3 Ds is dementia, depression, delirium. So dementia and pain. And pain management in dementia is very, very challenging because they don't say it, right? They don't say that they have pain, or they don't even recognize that they have pain, or they don't remember that they have pain. So it is very challenging. So this is my just the clinical tips that I obtained over years of experience, but also based on some textbook. But so these are the tips for assessing pain in dementia patients. So first, I strongly recommend to do whole body physical exam. Okay, if you suspect pain. So palpate joints. I know you listen to heart and then palpate abdomen, but often older adults, especially who's bedbound or debilitated, they have muscular pain or contracture, and then it hurts. So it's very important to move all the joints and then palpate joints, and then of course push abdomen, but basically whole body physical exam is very important. And then ask caregivers if patient complains pain or moan when they clean, right? So the nurse usually clean the patient, turn the patient, change position, and then often that's when patient feels pain. Okay, so even though if patient doesn't say, oh, do you have pain, and then patient doesn't answer or doesn't say that they have pain, but because they don't remember. Okay, so you have to ask caregivers, nurse, bedside nurse, if pain. I'm sorry, if the patient moans when they clean the patient. That's very important. And also, I'm sure you're familiar with 10, pain scale 0 to 10. 10 is the worst pain you can imagine, but sometimes this concept is difficult for them to understand. So if it sounds like, they're having trouble to understand 10, scale, might be better to ask them, is it a mild, moderate, or severe pain? And then also, I see a lot of, I work with fellows and then other trainees, and then they usually ask, oh, how long do you have this pain? Or when did it start? But if you know that a patient has significant dementia, that's not a good idea.
Yes, because they're stello, which is their
Yeah. It's not a good idea to ask them about the history, okay? And then what I would recommend is to focus on the current moment. What it means is that, do you have pain at this moment, right now? Do you feel pain? Because what happens is also they remember having pain because pain
I
is
had
very
trigeminal nerve
strong,
pains.
um, strong feeling. So they would say, oh, I have pain. But actually, if you ask them, like right now, do you feel pain? And then they say, oh, actually, I don't have pain right now. Or vice versa, right? So anyway, it is very important for you to focus just on current, and then don't ask about past or
So
how
Adler?
long. This just
Right.
can be
Adler
very
is which,
confusing. And
Will a
then-
Dr. Five please mute yourself, please? We can hear you. Sorry, Dr. Uemura, go ahead, please.
That's okay. Yeah, thank you. And also, it's very important to give them enough time to respond. Sometimes dementia patients have how do I say this? Like a very slow to respond. So ask them, oh, do you feel pain right now at this moment? And then you have to pause, okay, until they respond. That's very important. And then agitation or other behavior change can be a sign of pain. I'm going to discuss later, uh, furthermore. But I want to actually give you some story. So I had when I was in nursing home, I had a patient who has diffuse bone metastases from lung cancer, and then he came to my nursing home, and I saw him for the first time. And then when I saw him, he was laying in the bed and then like not moving, just laying still. And then I asked him, "Oh, do you have pain?" And then he said, "No, doctor." And but when I started examining him, meaning touching him a little bit, he's screaming pain and like very bad pain because of bone metastases. And then he screamed a lot during the my exam, and I finished the exam. And then right after the examination, I asked him again, "Do you have pain?" And then he said, "No, doctor, I don't have pain." And again, this reminds you that that if patient has significant dementia, they don't remember, and then they don't tell you that they have pain. Again, so that's why it's very important to examine. Also, don't take no pain, if they say no pain, but still they can have pain. Okay, so it's very challenging to assess the pain in dementia patient. So because of this challenge, there have been a lot of pain assessment tools developed in the research. So this is the whole, list of pain scores that have been developed, CNPI or Dolo plus two. They put very unique name, Mobid. I believe there's Mobid 2 now. There's so many pain score. And I'm not gonna tell I don't even know some of them what that is. But I'm not gonna tell you all of them. But one thing you may want to know is PAINAD. So it's abbreviation of Pain Assessment in Advanced Dementia Scale. And then in Mount Sinai, also we use this PAINAD useful scale for assessing pain in non-verbal patient, mainly designed for dementia, but you can use, I believe, for other situation like a stroke or any type of non-verbal situation. And then it goes assess 5 domains, which is breathing, negative vocalization, facial expression, body language, and then consolability. And then each item range from 0 to 2. And then because 5 domains, so the total number maximum is 10. So basically it's designed to correspond to 10 pain scale. So 0 to 10, and then 10 is the worst pain. And then it has very high sensitivity, so 92%, but obviously specificity is low, so 61%. Because, for example, if the patient is having labor breathing or moaning or rigid extremities, doesn't necessarily means that patient has pain. So specificity is low. So how can you differentiate high score or pain ad and from having real pain or not having pain? And usually what I tell the fellow is that I give it the uh, provide some pain medication to the patient with a high pain net score, and then assess if this pain medicine decrease the pain net. So there are also studies that showed actually if you use this pain net score as follow-up, meaning so pre-intervention and then post-intervention, and then if you compare and then there is decrease of pain net, that provide better specificity of pain. Okay, so you can use this as just a single point assessment, but it's better to use it as like a pre-post and then confirm that pain medicine decrease the pain at score, and then that gives you the confirmation that, okay, so now patient surely has pain. And then because this pain score is not developed for intubated or critically ill patients, so in a situation where the patient is connected to ventilator or anything like that, there's also this score, which is called CPOT, or Critical Care Pain Observation Tool. And this score also we use at Mount Sinai as well. And then again, so this is designed for critically ill patient, especially for those who are connected to ventilator because they cannot talk, right? And then pain at score has vocalization. So this is why there's CPOD. As you can see, so maximum score is 8, so which is different from pain at. But it's been validated in various settings, mainly ICU and the post-op. And then it's a useful score, but mainly similar to pain at, facial expression, body movements, muscle tension. And then the unique thing is that compliance with the ventilator. So you assess if the patient is compliant with the ventilator setting. And again, you can use this as a pre-post analgesic intervention. So pain in dementia patient can cause BPSD, meaning behavioral psychological symptom of dementia, mainly the agitation, calling out, refusal of care. So actually, American Psychiatric Association even recommend assessment for pain in dementia patient with BPSD. What it means is that, so if you see dementia patient, and who's agitated or calling out or anything like that, before just concluding this is dementia and then start antipsychotic, which is not recommended as a first line anymore, but antipsychotic or SSRI, before you started these medications, you want to assess for pain and to make sure there's no pain background. Again, they won't tell you, okay? So you have to actively look for pain and then palpate the joints, turn them, and then make sure that there's no pain behind it. And so if you treat the pain, actually behavior or agitation decrease. I know this is difficult to see, but basically what it tried to say is that pain intervention, so this is the control, and then this is the intervention group. But anyway, so the pain score, I'm sorry, agitation score decrease after pain intervention. Okay, but mainly opioid, this setting. However, the hallucination didn't increase. That's what I tried to say. But I know that many of people worry about using the opioid and then cause hallucination, delirium. However, treating the pain is still important. So that was dementia. That was a lot, okay, and they will be quick afterwards. So I'm gonna quickly talk about delirium, and many of you may know, but delirium happens in the predisposing conditions, and then when this patient had precipitating factors. Okay, predisposing factors meaning it cannot be modified, such as dementia, and then defines baseline vulnerability. And the precipitating factor means it's modifiable, and then these are the insults. For example, pain or infection or being in the ICU or not, sleeping, electrolyte abnormality. So these are the precipitating factors. So just to give you an idea how we geriatricians see delirium. And then these are the list of predisposing factor. I'm not going to go over. However, what I'm trying to say is that a predisposing factor, one of them can be pain. Okay, so again, assessment on pain in I'm sorry, and then assessment on pain in delirium patient is again challenging. They're confused. They cannot tell you if they're in pain. So it's very difficult, and they use the same principle as I talked in dementia pain case. However, also uncontrolled pain itself can cause delirium, and the odds ratio is 2.1. And then, but opioid use also can increase risk of delirium for sure, yes. Some studies show the odds ratio 1.4. However, I feel that uncontrolled pain is more risky, meaning important to treat first the pain, and then you can think about, oh, still maybe opioid can cause delirium. However, I think the pain, if you don't treat the pain and then control pain, it can be more dangerous and then can cause more likely delirium. And then because I'm talking about 3D, which include depression, so I just defined the research, some research that showed also pain itself increase the risk of depression. And then I'm sorry, what was this? Depression associated with pain was observed. Yeah, so some studies showed actually male patient tend to have more depression when they have pain. I thought it's interesting, but not a huge finding. But anyway, so that was meditation. And then next 4M framework is meditation. So absorption of medicine pharmacokinetic in older adults change in you studied this, right, in pharmacology in medical school, the absorption, distribution, metabolism, and the elimination, and that all these phases change in older adults. Absorption, not too much, but distribution for sure, because older adults tend to have more fatty, tissue, and also less muscle, meaning reduction of water, right? So that distribution change, mainly it can increase the level of medication. But also metabolism in liver decrease, and then elimination in kidney also decrease. So basically, the medication tend to be higher, the level can be higher in the bloodstream, but also tend to stay longer in the body. Right, so these things can lead adverse effects for sure. So adverse effect is the leading cause of admission in older adults. 3.6% of ED visits are due to medication adverse effects. And then it's very common reason for older adults for ED visit as well as hospitalization. And then prescribing cascade, that's how we name it. What it is that there's adverse effect, and then you add another medication to counter effect this adverse effects without realizing that actually it's caused by medication. So you add medicine, so that's called prescribing cascade, which is not good. So this is in general, it has nothing to do with pain, but in general, from geriatrician standpoint, it's always important to suspect medication adverse effect when you see some problem in older adults, especially frail older adults, until proven otherwise. But it applies to pain medicine as well, because pain medicine tend to have a lot of side effects. And again, if you see some problem, you want to think about, oh, actually it might be caused by medication or even withdrawal, right? It can cause withdrawal. For example, gabapentin, these type of things also can cause withdrawal. So you want to think about medication side effects. And I always calculate a creatinine clearance, and then do not use morphine when the creatinine clearance is less than 30. And this is the golden rule in geriatrics. So like mantra, so we always say start low and go slow, meaning starting the lowest dose possible and then increase slowly. Okay, so this applies to all the medication management in older adults, but including pain medication like opioid or like gabapentin, these type of things, start low and go slow. And then polypharmacy and the non-compliance is very, very common. Okay, why? Because the older adults tend to have very complex regimen and then too frequent administration. Again, they don't remember. right? And then the cost also can affect. And then you go to the doctor and then they change the regimen. A lot of specialists, they change each other, each of them change the regimen. And then patient have no idea what they're supposed to be taking. So it's also very important. It's in general, not specifically to pain medication, but also pain medication regimen itself can be very complex. But do not assume that patient is taking medication as listed in a medical record. When you go to, I don't know if you use Epic, but Epic and it shows you the list of medication, but doesn't mean that a patient is taking it. I recently, actually yesterday, I saw a patient actually, the list, and actually, if you ask them in detail, actually, they are not taking this medication for months, but still it's showing it in the list. So I used to do home visit because I was doing the, home hospice. This is not my picture, but it's my colleague's picture. But when she did the home visit, this is what she found in the patient's home. Okay, this is a bunch of bottles, and then many of them are same medication, but different, like a strength or frequency. They have no idea what they're doing. Okay, but this can happen if you just keep prescribing without realizing that patient is not taking it appropriately. So it's very dangerous. So that's the polypharmacy and the medication era. And that, there's a famous list which is called Beer's criteria, which lists the potentially inappropriate medication for older adults. And then it includes, of course, pain medication. So I just extracted some of the pain medicine that's listed in Beer's criteria. Doesn't mean that they cannot take it or you cannot use it in older adults. It says potentially inappropriate. But what it means is that you have to be careful when you use these medication in older adults. And then it's a tricyclic antidepressant, including amitriptyline. We use something for neuropathic pain, but it can cause, cholinergic effects. So anticholinergic effects and then other, side effects as well. So you have to be very careful. Olanzapine is the same. It's psychotic, but sometimes we use in palliative care. And then also NSAIDs, of course, it can cause a bunch of problems, and the muscle relaxant, including cyclobenzaprine. So these are the medications that's listed in Beer's criteria. And then it also talk about important interaction. So for example, opioid and then gabapentin, if you prescribe at the same time, of course, it can increase the sedation risk, right? So you have to be careful. Or any combination of 3 or more of SNRI, benzo, opioids, and the muscle relaxants. Again, you may have seen patient who's taking a bunch of them because they have chronic pain. But of course, you have to be careful in the risk of side effects. And then also, these are the medication that you have to reduce the dose in renal impairment, which is baclofen, duloxetine, gabapentin, and tramadol. For example, gabapentin, I believe max dose in renal failure is 300 milligrams per day. So you have to know, make sure that you reduce the dose. For example, if you see the patient who has AKI, you have to adjust the dose. And then PRNs, right? And then that's, I think, Latin language. I don't know even how to pronounce, but in geriatrics, PRN, actually, some people say patient received nothing. That's what it stands for. Why? Because patient with cognitive impairment or weakness, they don't ask for PRN, right? So you've seen a patient laying in the bed in the hospital or nursing home, even though there's PRN medication, if you go to the MAR, it's never been used. But doesn't mean that a patient is not in pain, or doesn't mean that the patient doesn't need pain medication. Basically, just the patient is not asking for it, and then so it's not being used. Okay, so sometimes we have to consider scheduling pain medication, especially when you suspect the patient has persistent pain. But make sure that you hold the medication if the patient is sedated for safety. And then just to quickly, it's always important to maximize non-pharmacological approach as well, such as physical therapy, massage therapy, tai chi, acupuncture, cognitive therapy, yada, yada, yada. But in Mount Sinai, we have massage therapists or even music therapists, of course, physical therapy as well. And I believe they do tai chi as well. So we do a lot. But it doesn't cause too much side effects. So even though the research has been, conflict and like a mixed result, but because it doesn't hurt too much, I think it's nice to have it. And then if you can use it, well, why not use it? So there's a guideline published by AGS, American Geriatrics Society, long time ago, actually 2009. And then for on pharmacological management of persistent pain in older adults. So I'm gonna just quickly give you key points from the guideline. So they recommend acetaminophen as the first line for persistent pain, and then consider opioid when moderate to severe pain and then functional impairment. And then utilize adjuvant analgesics such as SNRI or gabapentin, and they use topical agent. So nothing new, nothing new. But I just want to make sure that everybody knows that a Tylenol or acetaminophen is geriatrician's favorite, most favorite analgesic, right? Because it's safe, but also it is effective if you use it scheduled fashion. So if you're using just a PRN, it rarely works. But always, so what I do is 3 grams per day, meaning 1 gram TID, or in younger patients, you can use 4 grams per day. Okay, so you have to schedule. And then in liver impairment, you can use 2 grams per day. But so that's Tylenol. And then, so there are studies that examine the Tylenol effect in nursing home patients. So I'm not gonna go over in detail, but they compare the nursing home resident with the pain, and then Tylenol 3 grams per day or placebo. And then they measure the they spent in some activity, and then that showed the increased time in activity engagement. That means the pain improves, so they tend to go out more, or they can tolerate some of the activities. So again, what it means is that Tylenol 3 grams per day works for older adults. And opioids. So when the pain is not controlled with Tylenol, sure, you can consider opioids, even though it's controversial for non-cancer pain, chronic pain, but still, especially the AGS recommendation still says you can consider. Okay, so especially for continuous or frequent pain, and then you can consider using it around the clock. And then, but what I do is normally, the opioid lasts for 4 hours basically, but often I end up using it just a Q6 hours if you schedule, because there can be some renal impairment. So I try to start with the Q6 hours schedule dosing. Again, non-cancer chronic pain, there's no clear evidence of benefit opioid use. However, still, if it's important to treat the pain, you can consider for sure. However, you have to be very careful with the side effects. And also, if you become very chronic, I don't know if you want to introduce actually opioid. So you have to be very careful when you start the opioid for chronic non-cancer pain. But if you decide to, consider to use opioid, these are the things that I recommend to consider, right? So as I'm talking about outpatient, so who administered the pain medication? Is it the family member or is it the patient? So what it means is that can they handle, right? So usually there's a long acting and a short acting. Often they confuse, right? Or they may just take like, oh, I'm in pain, so I'm going to take 2 tablets instead of 1. Okay, so you don't want that. So you have to make sure that a safe environment to manage this pain medication at home, right? And then do they use pill box? Okay, so again, they may forget or confuse. So you may want to make sure that they use pill box, and then family distribute this long-acting medication in pill box so that they don't mess up with it. And then do they know that updated regimen and what they're supposed to be taking? And then again, if it's complicated regimen, they can get confused. Okay. And then again, long acting and short acting, do they understand? These are the things that you may want to consider. And then quickly, weak opioid. I think you've heard of this, weak opioid, right? And then we used to say WHO pain letter. You can see on the right-hand side, step 1 is non-opioid, but step 2 is weak opioid, and then step 3 is strong opioid. However, we don't use this. We means palliative care. In my practice, at least, we don't use weak opioid anymore. Why? Because it includes codeine, hydrocodone, tramadol, but especially for example, codeine, it's metabolized to become morphine. Okay, and that's how it works. Okay, so basically, you're giving morphine, but you don't know how much you'll be converted to morphine. So you have no idea what you're doing. So it's not weak opioid. It's same opioid. Um, so that's the point. And also in the US, weak opioid only available as combination pills, which come with Tylenol, acetaminophen, right? So you cannot keep adding this medication because you can exceed the maximum amount of acetaminophen if you keep increasing this weak opioid combination pill. So it's very inconvenient. So we don't typically use it. So rather, you should use a small dose of strong opioid, which is morphine or oxycodone or hydrocodone. That's what typically we do. And you may have heard of this, but also I don't typically use tramadol. There is a famous podcast in Jerry Powell, which is titled Trauma Don't. So if you're interested, you can listen to this. It's a great, episode. But basically, we try to avoid tramadol. Uh, the reason is, so there was a study that showed increased mortality risk in patient who's receiving tramadol for pain after adjustment of their background characteristics. But also tramadol itself is actually SNRI. So it's not opioid first, but it's metabolized to become opioid. And then, so it's a mix of SNRI and opioid. And then that's why you may have heard that it can cause serotonin syndrome or seizure, because it's basically SNRI, okay? And then it can cause significant dependency and withdrawal as well because of SNRI properties. And then you don't know how much it stays as SNRI and then how much it's converted to opioid because it depends on the expression of this CYP2D6 enzyme. And then it also can be affected with other medication. So basically, we rather stay away tramadol. It works, and then if you're using it, that's fine. But I think you have to be aware that what you are giving to the patient. And then when you use opioid in older adults, any medication, dysphagia can be a challenge. So you may want to consider how to administer opioid to older adults. So in short acting, again, dysphagia is very common, but there's oral solution of morphine is very useful, but there are multiple concentrations. So when you start using it, you have to be very clear what concentration you use. For example, in morphine, there are 2 milligrams per ml and then 20 milligrams per ml. So 10 times difference, okay? And then why there is high concentration? Because you can use it as sublingual. For example, if you want to use 5 milligrams of morphine with sublingual, if you use lower concentration, it can be what? 2.5 ml, which is too much for sublingual. But you can use with a high concentration, it'll be only 0.25 ml, which is just a couple drops, and then it can be absorbed sublingually. So there are multiple concentration, but it can cause medication error, right? So I had a patient actually who came to my clinic, and then she said, oh, medication doesn't work, morphine doesn't work. But I realized that she has lower concentration by using this very small syringe, which is supposed to be used for high concentration. So she was just using like a 0.2 of low concentration morphine, which is nothing, right? Or it can happen the other way, meaning the patient is prescribed with high concentration, but patient is using this huge syringe, okay? And it can cause 10 times, amount of error. So, which is very dangerous. So family needs to know how much they're supposed to be given. So this can be very dangerous, and to make sure that patient has correct syringes. And then when patient has dysphagia, long-acting opioid can be also challenged because many long-acting, mainly it's tablets, right? MS content, oxy content, or there's also extended release of hydromorphone as well. And then these are the tablets. And then you cannot basically, maybe you can, yeah, so you cannot crush it. So you cannot use, be a PEG or anything like that. So you cannot use it. There is an Extensa, which is oxycodone capsule, particle in the capsule, and then you can decapsule that one, and then you can put the particle in the feeding tube. So that might be useful. And also there's Cadian or other type of morphine extended particle as well, and then that can be given via NG tube. But also in that point, fentanyl patch can be, of course, useful, but FDA recommend not to use fentanyl patch when a patient is non-opioid tolerant, which is defined as oral morphine equivalent less than 60. So you don't want to use fentanyl patch. I mean, it can cause overdose for sure. So you don't want to start the fentanyl patch when the patient is opioid naive. And then quickly, buprenorphine patch. Some people use buprenorphine patch for older adults. I'm not going to go over it like in detail, but it's a partial agonist, so it should not cause respiratory suppression. So some people feel it's safer, and then some people use it as in older adults. And the initial dose is 5 microgram per day, and then change every 7 days, also which might be convenient for older adults. Let me skip this actually, I'm sorry. But one thing though I want to say is that buprenorphine patch as this study. So this study, they examined 44 patients who received the buprenorphine patch. It's from Europe. So that in Europe, they have longer history of using buprenorphine patch. And then they saw actually a significant adverse effect, which was sedation in older adults who's receiving buprenorphine patch. So even though buprenorphine patch may not cause respiratory suppression, but still it can cause sedation. So it's not like a totally benign, just a patch and that you can use anytime. It's not like that. Still, it can be dangerous. So you have to be just careful. And then low dose methadone. I actually use low dose methadone, and I know that the time is close to running out. So I'm not gonna talk in detail, but methadone, and then usually it's in range of 30 milligrams, 40 milligrams when you use. However, methadone can be used as little as 1 milligram twice a day. And actually it can be useful in older adults. When I was in nursing home, I started using this, and it was very, very helpful. It comes with the liquid form, and then it can work for any, like a neuropathic pain. So it can be very useful. So I published this short article in JAMDA. So if you're interested in this, you can read this. So I'm gonna skip this. So quickly, mobility. So the pain, of course, can cause mobility issue. And then again, you see the patient in the hospital and that they're not moving, right? And then they're in pain, but they're not moving. And then when they are not moving, they don't have pain. So if you ask the patient, do you have pain? Oh, I don't have pain, but they cannot move. And then they don't realize that they're not moving. But it's not your goal, right? I mean, patients should be walking and then discharge, right? So they need to do physical therapy. So in order to do that, you may need to be a little bit more aggressive, even though patient says no pain at rest. Okay, and then the pain medication, PO opioid works, peak effect is in 1 hour, and the IV opioid is 15 minutes. So if you do physical therapy and then patient is in pain when they do physical therapy, you may want to get PRN opioid. If it's PO, 1 hour before, and then if it's IV, 15 minutes before the physical therapy, and then that can be helpful. And of course, many analgesic can increase the risk of fall, so you have to be just careful. And then especially muscle relaxants like cyclobenzaprine or baclofen or tizanidine, these are the things. Actually, we don't know if it's gonna work and also increase the risk of falls and the other side effects. So you have to be just careful if you want to use it. And then finally, what matters most. So clarifying goals is very crucial in pain management because how aggressive the pain management should be depends on goals of care. Because you have to balance the risk and benefits, right? So I talked about full risk, delirium or sedation, but also pain management is important. So how do you balance that is important. And then it depends on the goals. For example, maximizing the rehabilitation is important. Maybe you may want to be more aggressive, even though there's a fall risk, right? So again, clarifying the goal is important. And depending on also the prognosis of the patient. For example, if the patient's prognosis is shorter, maybe you may want to optimize pain more, even though there is risk of side effect. So, but if the patient has, for example, more than 10 years to live, you may not want to even introduce opioid, right? It can be very chronic. So it depends on the prognosis as well. So you have to know what the prognosis of the patient is. When you clarify the goals of care, you have to have good communication skills. And then I'm sure many of you know this, Vital Talk. This is a great organization that provides communication skill training. In our department, Mount Sinai, Palliative and Geriatrics, all of us are trained in Vital Talk. So if you don't know, you may want to check it out. And then these are the what is it? Conversation frame they use, which is called Remap. So I'm gonna skip this. Okay, so take home points. So pain management in older adults is very complex, and the apply for an approach to guide individual care can be useful. And assessing pain in cognitively impaired patient is challenging, and leveraging tools like PainAd, and then also if the patient, for example, is agitated, these behavioral observation can be very helpful. And side effects from analgesics are very common, and they follow the golden rule, which is start low and go slow. And pain significantly affect function and quality of life. So treat proactively to support rehabilitation and well-being, and clarifying goals and align pain management strategies with each patient's unique needs and priorities. That's all. And then this is the CME code. Any questions?
Dr. Uemura, hi, Dr. Clapbolt's here, Chair of Medicine. Thank you so much for this very important and very, very highly informative presentation on a really complicated topic that I think
Sure.
probably all of us struggle with all the time. So
Sure.
really thank you for all these insights and comments that you noted. We have a few minutes for questions, so I'll encourage folks to raise your hand, speak up, put it in the chat. While we're getting that going, let me just ask you, it was interesting, I mean, there's so many things to pick up on what you spoke about, but this issue about using the partial agonist methadone and buprenorphine for the pain management, and the fact that their side effect profiles are probably less. Do you using that as first line, or how are you doing that?
Sure. Yeah. So buprenorphine, yes, it can be used as first line. I don't have extensive experience of using buprenorphine, to be honest with you. But I used, as I said, low dose methadone. Again, I was using it in nursing home, so it comes as liquid. So I don't think I will be a little bit more hesitant if you use it in outpatient setting. For example, it can cause, dose error. And then also who prescribed this can be a challenge. So I'm not recommending to everyone. But yeah, so it can be used as a first line. There are actually multiple studies that show that low dose methadone can be useful because methadone has NMDA antagonism that prevents actually opioid tolerance development as well. So if you use it, a methadone as first line, actually the dose can be very stable. And then I had a patient who started in 1 milligram twice a day, and then she stayed that dose for more than a year, and then she was, fine. So yeah, it's something you can keep it in mind, but it can be very tricky which patient to use. So it may not be for everyone. Yeah.
Yeah, I see that thank you so much. I see that Dr. Chin picked up also on that. And he was getting into a little more detail, I guess, as you guys deal specifically with different conditions. He asks, are there certain conditions where you'll choose methadone versus morphine?
Oh, sure. Yeah. So the reason why I started, so maybe I shouldn't have skipped this topic too much. I'm sorry.
It's okay.
But reason why I started using this is, again, it's because of dysphagia in nursing home population. For example, morphine, again, I mentioned Cadian, but it's not available normally in nursing homes. So if you want to use morphine, you have to use MS content if the patient needs like a scheduled dose, or you can use short acting every 4 hours, every 6 hours, but that's too much for nurses. And then that's why I started using methadone, because it can be only twice a day and then it's long acting. And then also methadone works well for neuropathic pain. And also in my experience, wound pain, ischemic pain, or any type of pain. I had a patient who had the stroke, and then he has like a hemi, like a pain because of thalamic pain. He has like a thalamus stroke, and then he was on oxycodone, but it was not working. And I started just the low dose methadone, and then it disappeared. Pain disappeared. Also, I know that a terrible trigeminal nerve pain, and then my colleague started the low dose methadone, and then she was able to eat. She was able to go out. Yeah, so it's very effective, especially when there is a nerve pain component.
That's great. Thank you so much. I think we have time for another question or so. If anybody would like to ask. Just ask you real quick, this intersection and the nexus of these conditions of pain, agitation, delirium, depression, all of which you kind of alluded to. Do you find yourself or do you treat sometimes multiple conditions, or are you really, focusing on pain and then waiting to see if the others clear up? How do you deal with that when perhaps there's presence of multiple conditions?
Oh, I see. So you're saying that a delirium patient, and that there might be pain, but also other factor can be contributing. Yeah, of course. So we get, geriatrician get the consult for delirium, and then of course we do comprehensive assessment. And if you identify something that can be modified, for sure. I mean, you treat pain, but also you remove other stuff as well at the same time, or it depends. But of course, I think it cannot be just the pain itself. Of course, it's always multi-component, so it's important to treat other things as well. And then you never know which single one was the most contributing factor. Often it's a multi-component.
Okay, thank you. I think our time is up. I want to thank you, Dr. Uemura, again for a really informative and presentation on as I said before, a complicated topic that I think all of us have to deal with and often struggle with. So these were great insights to this issue. I want to thank everybody for joining today. I think we had great attendance, and I want to wish everyone a great rest of the day. Thanks so much.
Thank you so much for having me.